Hi guys, welcome you all to November 2002 INICET ADrPlexus Pathology Recall questions. So how was your exam? So I hope all of you done reasonably well. And there was a mixed kind of responses from your people, like how was the paper? So some were saying that it was a tough paper, and some were saying that okay, many of the things actually from the IELTS topics. Yes, we do all feel that most of the questions actually from high yield topics as well as the repeat topics, and those things actually which you would have solved the previous year papers definitely would have got an idea, and some questions actually very repeat from even from the last NEET exam also. So, and we are very happy to say that actually most of the questions which are asked from pathology and related things, actually almost everything actually what we have discussed from our set of workbook series. So let us see what are the questions. Actually, this session actually will be seeing both the questions asked in the morning session as well as in the noon session. So let us start our discussion with the first question. So which of the following molecules helps in the migration of the WBC from the blood vessels with adhesion across the endothelium? So this was the question asked, and this is directly asking you what are all the molecules. So it is like a recall based questions actually it was asked. And if you see from our notes from the workbook, you can see there are mainly these molecules actually for the rolling. For the rolling inside the blood vessel to take place, you have E-selectins expressed on the blood vessel endothelium, and you have silent Lewis molecules. So on the WBC, so these molecules helps in the rolling, and for adhesion you have integrins. For adhesions we have integrins, and you can see from our workbook actually we discussed that for migration. So for migration actually we have discussed and highlighted that PCAM1, that is CD31, which is expressed both on the WBC cell surface as well as on the endothelial surface, helps in the exit of the cell, that is the e-migration or diapedesis of the WBC from the vessel lumen and into the out of the blood vessel. So we can directly see this point was already insisted that PCAM1 and CD31 helps in the e-migration. So the correct option here will be the migration. Since they have asked about the migration of the WBC, so the correct option will be the PCAM. That is the CD31 will be the correct answer here. So E-selectins will be helpful for your rolling, and alpha integrins and ICAM will be helpful for the adhesion of the cells. So PCAM will be helpful in the migration, that is the E-migration or the diapedesis. So let us move on to the next question. Actually, this is a very well repeat question. That is, the image of the bone marrow aspirator was given, and a child with splenomegaly and bone marrow involvement and bony pains actually was given. So, and this image is a very classical image, and almost every one of you will be very familiar with this kind of image. And please, actually, like all of you would have known that last NEET exam also, this INICET, and this was repeatedly asking the same kind of image and same kind of question. So all of you are very aware that these are all the macrophages. These are all the macrophages which are present in the bone marrow, and which is containing the undigested material, that is the glucocerebrosides. Yes, these are nothing but the macrophages, as you can see from our workbook which we have discussed. So these are all the Gaucher cells, typical Gaucher cells, and these Gaucher cells have contains the macrophages with the glucocerebrosides, and the characteristic appearance of these macrophages is the crumpled tissue paper appearance. Yes, this is a crumpled tissue paper appearance. As you can see here, we have discussed from our workbook, exactly the same thing came. Actually, the enzyme, because of the glucocerebrosidase, lack of deficiency of this glucocerebrosidase, and the disease points out here is the Gaucher's disease. Here, the disease is Gaucher's disease. So you can see this is a very well repeat topic, and all of you, I hope all of you would have done this answer correctly. So now move on to the third question. A 25-year-old female presented with a neck swelling. So female presenting with a neck swelling, and I think in the question stem they have also given the swelling moves with the deglutition. So on examination, the lesion is invading the strap muscles of the neck, telling that this is an invasive tumor. It is an invasive tumor. So what is the most likely diagnosis? So very important point to be noted down here is the image was given for this question, and image you can see they were given something like a cross section, like these are all the cross sections of the papillae, that is a papillary projection, that is a finger like projections. These are all the papillae which are seen in the cross section. So as you can see here, you can have this central fibrovascular core, and the papillae are lined by the tumor cells which have a clear chromatin. Actually, there is a difference of opinion whether this image given was having a exactly the so-called ground glass nuclei or orphanani nuclei, but most of you are very sure that it was like a papillary pattern. So with this taking into account, this is will be a diagnosis of a papillary carcinoma of the thyroid. So the history points out towards a neck swelling moves with the deglutition and invading the strap muscle, tells you that this is actually an invasive tumor. And with this papillary projections and this orphanani eye nuclei and the central fibrovascular core, you can have this papillary carcinoma thyroid. So this is not a follicular carcinoma thyroid, because follicular carcinoma, you will be having the follicular arrangements of the tumor cells. And also to call it as a follicular carcinoma, what are the two things essential? It is vascular invasion as well as and capsular invasion. Both invasion should be there to call a follicular lesion as a follicular carcinoma. So it is thyroiditis. It is a non-neoplastic one. That is, it is a fibrosing lesion which can constrict and causing an obstructive symptom all over the neck. Okay, resulting in the obstructive respiratory obstruction. So those things will be there. So thyroglossal cyst will not have a infiltrative nature like invading the strap muscles, and also will not have this kind of papillary projection. So with this, we are coming to a diagnosis of, this is a diagnosis of papillary carcinoma of the thyroid. Yes. So as you all can see, the exactly the same thing actually we have discussed during our workbook discussion, and we have discussed about the papillary pattern and all the cellular changes. So orphanani eye nucleus, which is characteristic of papillary carcinoma of the thyroid. Moving on to the next question, a 45-year-old female who is a non-smoker was diagnosed with adenocarcinoma of the lung. Which of the following marker is positive in this patient? So remember, dear students, actually these sort of questions. So like morning one sort of tumor with given, they have given the IHC and they have asked the diagnosis, and in the evening session they have asked a similar tumor with the another IHC markers. So actually the question pattern, if you see from the morning and evening pattern, there is not much of any difference in the range or the toughness of the question. So all are of equal standard, both the morning sessions and the equal standard. Like morning they have asked about metastatic calcification, evening they have asked about dystrophic calcification. Morning they have asked about some vaccination related in HPV. In the evening session they have asked about the proto-oncogene. So morning they have asked about, given about the IHC positivity in certain tumor, and they have asked a diagnosis, and in the evening also they have asked a similar question. So how to approach this case? So for approaching this question, all of us should definitely will be recollecting what are all the IHC markers positive in different types of lung cancer. So as we dealt during our class and during our workbook discussion, so you can see here they are asking you the given you the diagnosis of adenocarcinoma of the lung, and they are asking you what are all the markers positive in this patient. So definitely we will recollect what are the markers which are positive in the adenocarcinoma of the lung, as it was insisted very much during our discussion. Like you can see here, we have highlighted this TTF1 and napsin A, and we have also told TTF stands for thyroid transcription factor. So this TTF marker is positive in thyroid tumors as well as in the lung tumors. So to make a diagnosis of adenocarcinoma of the lung, it is positive for TTF1 and napsin A. So as highlighted here, so the answer here is going to be a napsin A and TTF1. So definitely we'll have another question on about the IHC markers. So synaptophysin, chromogranin, NSC, Bombay, CD56 all are positive in small cell carcinoma. They are positive in small cell carcinoma of the lung. And P40 is positive in the squamous cell carcinoma of the lung. And NAPSING and TTF1 are positive in the adenocarcinoma of the lung. So definitely IHC based questions are being repeatedly asked in these kind of things, and definitely for upcoming NEET exams there will be a similar questions we can expect from these kind of IHC markers. The total next question. They've given a total WBC count of a patient which is 4,50,000. So the total count was markedly elevated. So such a markedly elevated. So definitely we'll be thinking of a leukemia as the first differential. So what is, let us see what are all the other options which are given. So they have seen that it is increase in the myeloid series with the right shift. This word was the right shift with the myeloid series with the right shift, eosinophilia and basophilia. So this is, guys, all of you will be definitely knowing and remembering that eosinophilia and basophilia together increasing in the myeloid series, and also the total WBC count increased in lakhs. So we will be making a diagnosis of myeloid series, and that too eosinophilia basophilia, that is the mature cells predominating in the peripheral smear and in the bone marrow. So this will be a diagnosis of chronic myeloid leukemia. So chronic myeloid leukemia, how we have arrived at the diagnosis? Because we have arrived at the diagnosis of leukemia because the total count was increased, and it is mainly an increase in the myeloid series, and also it is eosinophilia and basophilia. So all of us know that for basophilia an important differential is the chronic myeloid leukemia. And as you can see, this is the answer here is the chronic myeloid leukemia. And obviously, as you all can see from this thing, we have discussed enough about this chronic phase, three phases of chronic myeloid leukemia: chronic phase, accelerated phase, and the blast crisis. So this point definitely I would have insisted many times in our lecture classes. So this in chronic phase, the blast cells are less than 10%. Yes, in chronic phase, the blast cells are less than 10%, and the basophils are also less than 20%. Basophils are less than 20%. So suddenly in the next phase, what will happen? Accelerated phase, the blast percentage increases to 10 from 10 to 19 percentage, 10 to 19 percentage. And in the blast crisis, you can see the blast count will be more than 20%. So calling it as a CML transformation into AML. So this is the numbers you have to remember. So next exam, so related questions can be definitely asked related to this topic. Coming to basophilia, in chronic phase, the basophils will be less than 20%, and in accelerated phase, the basophils will be more than 20%. This is very important, guys. These numbers may confuse you, but easily remember: blast less than 10%, chronic phase 10 to 19%, accelerated phase blast crisis more than 20%. Basophilia, chronic phase less than 20%, and in accelerated phase basophilia more than 20%. So this is an important thing. And definitely we would have you will be remembering the things which we have discussed, that is the garden party appearance of the CML. So garden party appearance, all the cells will be of different types. That is, you can see here the neutrophils, and also you can see one basophil here. That is the blue granules. You can see the blue granules, and also this spectacle shaped nucleus with the eosinophilic granules. That is the eosinophil. And you can also see myeloid cells and also the myelocyte. So this type of appearance is called as the garden party appearance. And also you will be remembering the Philadelphia chromosome. Yes. Coming to the next question. Which of the following conditions show eggshell calcification? Though it is actually a radiology question, actually we have discussed during our workbook discussion, especially in systemic pathology, when I was teaching you with this silicosis and colorectal pneumoconiosis. I was talking you about this eggshell calcification, and I have listed out the causes of eggshell calcification during our classes. And if you can see, exactly the same kind of options were asked in these exams, like as I have told, like silicosis, sarcoidosis, post-irradiation, Hodgkin's, and there's options were also here: silicosis, sarcoidosis, and lymphoma after radiotherapy. So if it is a multiple options correct question, so the three options are right. That is silicosis, sarcoidosis, lymphoma after radiotherapy will show your eggshell calcification, whereas a metastatic lymph node will not show eggshell calcification. If it is all or except, then we have to choose metastatic lymph node. But silicosis, sarcoidosis, and a lymphoma after the radiation therapy will definitely you can see this eggshell calcification. And also you will remember this osteoclastoma, that is the giant cell tumor, which will showing this soap bubble appearance. It will be having the similar eggshell calcification. Okay. Then moving on to the next question, what is the immunohistochemistry panel of basal type of breast cancer? So we have discussed in detail about this IHC markers in positive in your breast cancer and the molecular classification of the breast cancer. So students, actually we have discussed enough of this basal type of breast cancer, and if you can see from our workbook, actually we have discussed about this. What is basal like? That is a triple negative. Triple negative, we insisted that it is ER negative, PR negative, and HER2 negative. We have also discussed that this is all a very poorly differentiated tumor, with many of the times you will not have DCIS at all in these cases. So even when they are very smaller in size, these tumors will have metastasis to the widely to the viscera and also to the brain also. These tumors are aggressive tumors, can have a rapid growth, and even after surgery, recurrence is common in these tumors. So with this, actually, we have discussed enough of this triple negative cancer, that is triple negative. All the three markers are negative. So you can see from the options, triple negative, that is ER negative, PR negative, and HER2 negative. So this is the correct option which we have to choose in this question. So triple negative, ER, PR, and HER2 negative. So this is the cancer, breast cancer, which with very poor prognosis. Okay. So next question is like a match the following type of question. We have asked about the types of the cells and in which conditions they are seen. So guys, actually these questions are also actually we have discussed in different places during our discussion in the workbook. And if you can turn our pages of the workbook, you can see like we have given you the picture of phagot cells. Phagot cells are nothing but these cells are actually seen in AML with a lot of oil rods. So phagocytes or not, phagot cells are nothing but these are all the myeloblast, which contains a lot of clumps of this oil rod. So you can see here, there's actually we have highlighted that these are all the phagot cells with a lot of oil rods, and these are all the phagot cells which you can see in your APML, that is acute promyelocytic leukemia. And what are Sézary cells? Sézary cells, actually, as we have discussed, Sézary cells are nothing but these will be having the characteristic cerebriform nuclei, as we have discussed during our discussion. So cerebriform nuclei, these Sézary cells will have a cerebriform nuclei, and these are characteristically seen in your mycosis fungoides. Mycosis fungoides, yes. So Sézary cells are seen in your mycosis fungoides. Caesary cells are seen in mycosis fungoides. Then the starry sky appearance you can see in case of a Burkitt's lymphoma. So Burkitt's lymphoma being a very aggressive tumor, the proliferating lymphocytes, actually lymphoid cells, will go in for apoptotic death. So the macrophages and the lymph node will engulf those nuclear debris, and the macrophages which has got engulfed with this nuclear debris will be showing you this starry sky appearance. So you can see a background of blue sheets of blue tumor cells, and you can see here and there these macrophages which have engulfed the apoptotic lymphocytes. So this kind of appearance we have discussed as starry sky appearance, and exactly the same thing was asked. Okay, and the next thing is popcorn cells. Popcorn cells are nothing but these are all the types of Reed-Sternberg cells which are characteristically seen in nodular lymphocyte predominant type of Hodgkin's lymphoma. Yes, popcorn cells actually because of the appearance of this convolutions in the RS cell, these kind of cells are called as popcorn RS cells, and these cells are actually characteristically seen in cases of your Hodgkin's lymphoma. So you can see here they're given the options. So this Sézary cells are seen in mycosis fungoides and popcorn cells are seen in Hodgkin's lymphoma, especially this nodular lymphocyte predominant Hodgkin's lymphoma, and the starry sky appearance is seen in your Burkitt's lymphoma. Then the next question, exactly the type of the bone marrow aspirations needle, which we have discussed during our discussion. The same thing actually came here. What is the name? They have you shown you the image of the aspiration needle, and they have asked what is that thing. So they have given the options as this is a type of the needle which is shown was shown in your exams, and the options were Jamshidi, Sala, Klima, and Islam needle. So the same things actually we have discussed enough about this bone marrow aspiration, and you can see here the difference between this Klima needle and the Sala needle. This both the Klima needle as well as the Sala needle will have a guard. But that adjustable screw, if it is there, it is a case of a Sala needle. So Sala needle will have a screw. So you can remember S for S. So Sala needle will have a screw. This Klima needle will not have a screw adjuster. So in the image which was given here, it doesn't contain any of the screw. So the answer here is the Klima needle. So without the screw and in the guard, actually the diagnosis of the bone marrow aspiration needle is the Klima needle. Coming to the next question, that is a 10-year-old boy presented with a hemoglobin 7.8 and MCV 57. So they have given you a case of a 10-year-old boy. So a pediatric age group patient presenting with a low hemoglobin and MCV 57. So it is a case of microcytic hypochromic anemia. So from that itself, we are making a first conclusion that HB is also low and MCV is also low. So we have know the differential diagnosis of our microcytic hypochromic anemia. So what are the things I told you to remember? I told you to remember CETA L, that is sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease, and lead poisoning as the differential diagnosis of microcytic hypochromic anemia. So here straight away we are ruling out the option of a sickle cell anemia as it doesn't comes in the differential of a microcytic hypochromic anemia. One important clue they have given you is the ferritin is 140, and they have given you the normal values of ferritin for a pediatric age group. So for a 10-year-old boy, this ferritin of 140 is normal. The ferritin of 140 is normal. So this is a very important clue in the question which will help us to differentiate between all these three conditions, that is iron deficiency anemia, thalassemia, and anemia of chronic disease. Let us see from our workbook discussion, exactly we have given you this tabular column and we have insisted that definitely this is going to come for the exams, and exactly the same thing has come. So let us see what will happen to the transfer. See this. This they have given the ferritin as 140. So let us see what is happening in the ferritin in this thing. So we have highlighted and said that the ferritin will be reduced in case of iron deficiency anemia. Concentrate here. The ferritin will be reduced in case of iron deficiency anemia and raised in case of anemia of chronic disease. So here the ferritin level is normal. So that way we are ruling out iron deficiency anemia as well as anemia of chronic disease. So here the ferritin level is normal. So we are making a diagnosis of thalassemia minor here. So thalassemia minor. The ferritin is an important clue given in your question by which we have ruled out iron deficiency anemia and anemia of chronic disease. If you can see the other clues which are given in the things. Actually, they are the extra points. That is, the total WBC count is 7,400. And being a pediatric age group, please remember, being a pediatric age group, lymphocytes will be the predominant cell in the pediatric age group. So this cell count, that is a differential count which was given in your question, is normal for that age. That is a lymphocyte 60% and neutrophils 30% is normal for that age. So with this ferritin 140 normal for a 10-year-old boy with a microcytic hypochromic picture, we are making a diagnosis of thalassemia. Let us move on to the next question. Which of the following is not an example of metastatic calcification? So this question actually was asked both in the morning as well as in the evening, as I said earlier. So one session they asked about the dystrophic calcification. Other session they were asking about metastatic calcification. So all of you will be knowing that dystrophic calcification occurring in the dead and degenerated tissues with normal calcium levels. Whereas metastatic calcification, increased calcium metabolism because of the deranged calcium metabolism, that increased calcium depositing in different organs is the metastatic calcification. So if you can see here, the parathyroid adenoma, there will be hypercalcemia. Vitamin D toxicity, yes. Hypervitaminosis, definitely there will be a hypercalcemia. And a chronic renal failure, all these things will cause a metastatic calcification. Whereas in rheumatic heart disease, you can get dystrophic calcification. So the answer here is rheumatic heart disease, because rheumatic heart disease, you can get dystrophic calcification. Like many other questions, this point are also well explained in our workbook. And you can see here, dystrophic calcification, rheumatic heart disease, and metastatic calcification. You have primary hyperparathyroidism, metastasis, multiple myeloma, sarcoidosis, chronic renal failure, milk alkali syndrome, and so many causes are there. So guys, please remember, this is a very easy question, and definitely you can crack this question in your, if it comes in your upcoming NEET exam also. So let us move on to the next question. In patients with bad lymphocyte syndrome, the inability to elicit and graft versus host disease is due to the deficiency of. So before solving this question, so let's see the notes what we have given in our workbook. So bad lymphocyte syndrome is nothing but actually there will be a there will be a mutation in the transcription factors required for the class 2 MHC gene expression. For the MHC gene to be expressed, there will be certain processes will be going on. But what will happen in this syndrome, there will be mutation of the transcription factors will be occurring, and so class 2 MHC will not be expressed because of the mutation. So what will happen when the class 2 MHCs are not expressed? There is nothing to stimulate the development of CD4 cells. All of you are aware of these factors, no? This CD4 cells will be interacting with MHC2 molecules, and CD8 cells will interact with the class 1 MHC molecule. Class 2 MHC, it is CD4. Class 1 MHC, it is CD8. So, in bad lymphocyte syndrome, mainly it is class 2 MHC gene expression will be affected. So, both the cellular and humoral immunity is affected. So, the patient will not be able to mount an graft versus host disease. So, there will be a defect in this graft versus host disease. When a patient receives the transplant, so there will be an inability to elicit this graft versus host disease. So, the answer here is the MHC2 will be the preferred one, that CD4 cells, because MHC2 is the expression is the predominant event. That is the first event which is occurring in the bad lymphocyte syndrome. So MHC2 will be the correct option. So a very easy question. The next question, that is the match the following they have given. So they have given the types of the cells and they have asked their location. So where are these Clara cells located? Clara cells are located in the bronchioles, And dust cells. What are dust cells? Dust cells are nothing but these are all the alveolar macrophages. So dust cells are nothing but they are the alveolar macrophages, and they are located in the alveoli of the lung. They are located in the alveoli of the lung. And Kupffer cells are the modified macrophages which are located in the liver, and parietal cells, obviously we know, which secrete the intrinsic factor, is located in the stomach. So this is a very easy question, and as we know, these are all the things actually we have discussed in the workbook also about the various macrophages and the cells. And another very easy question which can be definitely answered by most of you, that is the markers positive in the Hodgkin's lymphoma. So this was asked as a multiple option question. So the markers which are positive in the Hodgkin's lymphoma is CD15 and CD30. CD15 and CD30 are the markers, I would say markers, which are positive in the Hodgkin's lymphoma. CD19 is a B cell marker. It is usually not positive in this Hodgkin's lymphoma. And CD3, which is a T cell marker, is also not positive. So the correct answer here is the CD15 and CD30. Like this point also, actually, we have discussed during our discussion in our workbook. That is, actually, we have seen about the CD15 and the CD30 expression in different types of the Hodgkin's lymphoma. Different types of the Hodgkin's lymphoma. So another very actually a standard question. This was asked in the afternoon session. A 28-year-old female presented with weakness, pallor, and the complete blood count of the reveals hemoglobin was 9.6 and MCV was 58. Again, it is a case of microcytic hypochromic anemia. Remember, students, this microcytic hypochromic anemia, the table column which I showed you, and also the images, definitely minimum 2 or 3 questions are being asked in the NEET exam as well as in your INICET exam. So please remember that is a very high yield topics, and examiners are not tired of or not fed up of asking that question. So definitely they are asking these type of questions in every exam. So prepare well for your upcoming NEET exams. Also just revise the table column which I have showed you. Okay. So hemoglobin of 9.6 and MCV 58 makes a diagnosis of microcytic hypochromic anemia. And here the WBC count is normal, that is 11,000. So they have given you the image of a peripheral smear. So in the peripheral smear, what you are observing? So you are observing a microcytic hypochromic cells. You can see the cells with increased central pallor. So normally central 1/3 should be pallor, but you can see this my hypochromic cell that is increased central pallor, and you can also see this microcytic cells. Okay, you can also see this microcytic cells. And also you can see this anisopoikilocytosis, that is a variation in the size and shape of the RBCs. You can see somewhat pencil shaped, or this is the teardrop cells which you can see here. So you can see with this anisopoikilocytosis and microcytic hypochromic cells, and with this also a microcytic hypochromic picture in a female of reproductive age group, the diagnosis here will be the iron deficiency anemia. So megaloblastic anemia, usually the MCV will be more than 100. And in thalassemia, actually thalassemia major, that's in the anisopoikilocytosis will be more marked. And actually the patient will not be presenting with these kind of clinical features. Okay. So repeated history of the blood transfusions and all those things will be there. And essential thrombocytosis, I think one question was asked in the afternoon session. What is essential thrombocytosis? It is coming under the chronic myeloproliferative disorders. Platelet count will be increased. Platelet count will be something somewhere around some 10 lakhs or 11 lakhs. So that those kind of actually increased platelet count will be there in case of a essential thrombocytosis. So what are the platelets? Actually, these are all the platelets. You can see here, these are all the normal platelets. In a single field of oil immersion, you can see somewhat around some 10 to 12, 10 to 15 also platelets. So, but in essential thrombocytosis, what will happen? You will be seeing fully fields, all we will be filled with this small platelet. So that is the case of essential thrombocytosis. Okay, so these things also we have discussed about the various morphology of these cells which can be seen in a microcytic hyperchromic anemia. We have discussed the pencil-shaped cells and also the pessary cells and what are all the findings in the bone marrow and all these things during our workbook discussion. So moving on to the next question. They have given you the image of your peripheral smear of your patient and they've asked you the diagnosis. So a image of similar nature was given in your exam. So it is mainly what you can see here is the mature lymphocyte. So all these cells are the mature lymphocytes. So it is a lymphoid tumor. So you are seeing lymphocytes. So it is a lymphoid tumor. So it is a mature cells. So mature cells, if you see, it is a chronic lymphoid origin. Chronic lymphoid origin. So out of this thing, the chronic lymphoid origin is the CLL. Another characteristic point which is adding up to our diagnosis is the presence of this cell, that is, these are all the smudge cells or the smear cells. Smudge cells or the smear cells. I hope you will all remember the point which we discussed, that is in CLL, it is nothing but most of the cells will be having a uniform like mature lymphoid cells. So it is called as a convent girl appearance. And you will remember that CML we have discussed, that is a garden party appearance. So this point, please remember CLL, it is the cells are called as a convent girl appearance, and the CML, it is a garden party appearance. Okay, so this is a case of CML. Sorry, CLL. Senile atrophy is because of, so senile atrophy, that is the atrophy, that is a decrease in the size as age advances. What is the cause for the atrophy? That was asked, and it was the thing exactly we have discussed as ischemic atrophy. So we have discussed the same thing, ischemic atrophy, that is due to the reduced blood supply, there is senile cerebral atrophy. That is atherosclerotic plaque developing on the vessel walls will be leading to ischemia. So that ischemia will lead on to the reduced protein synthesis, and also the organ or the cell size will be decreased. So guys, please remember senile atrophy is because of the reduced blood supply. Reduced blood supply. Coming back to another very important and very interesting question, that is a patient presented with a gastric mass. And they have, again, as I insisted, they have given you the IHC markers, that is the CD117 is positive. So CD117, that is nothing but that is the C-kit, and it is positive in case of this gastric mass. So patient presenting with the gastric mass and the C-kit positivity, that is CD117, it is none other than our gastrointestinal stromal tumor, that is the GIST. GIST. Please remember, cytokeratin, they have said that it is negative. So cytokeratin positive means usually you will be thinking of a adenocarcinoma, that is the epithelial origin. S100 of something like a neural origin. So cytokeratin and S100 are negative, and CD117. What is the other marker which can be positive in GIST? That is dog1. What is dog1? Dog1, please remember, dog1 is nothing but detected on GIST. That is a very specific marker for GIST. As you can see, this point also actually we have discussed, and the cell of origin for the GIST is the interstitial cells of Kajal. And we have discussed that CD117, that is a C-kit, and we have also discussed that dog1 is the most specific, and imatinib is the tumor response to imatinib. So moving on to the next question, that is, which of the following cytokines are involved with the T helper 1 cells response? So this time actually INICET, they have focused, actually given much weightage to the cytochemical mediators, especially the cytokines and that is the interleukins. So they have asked even in a single session itself for some 2 questions, and in the afternoon session also about they have asked the questions when they regarding this interleukins. So guys, please remember, when you're going for your NEET exams, if you're settled in INICET, it is well and good, but when you're preparing for the NEET exam, definitely go through this interleukins. So definitely the NEET exam also, there will be questions we can expect from your interleukins. So let us see in T helper 1 response, what are all the cytokines which are involved. So definitely you can see from our notes, actually we have said that it is mainly interferon gamma and interleukin 12. Yes, so interferon gamma, interleukin 12, and even interleukin 2 is also involved with the T helper 1 cell response. And you can see from our notes, like actually T helper 2, T helper 2, it is mainly interleukin 4. Okay. T helper 2, it is mainly interleukin 4. So this is involved. Interferon gamma is involved with the T helper 1. Interleukin 12 is involved with the T helper 1. And interleukin 2 is involved with the T helper 1. And interleukin 1, that is involved in T helper 2 response. T helper 2 response. Okay. So now let's see the other question. That is a 28-year-old strict vegetarian, actually male, presented with a pallor and weakness. So paleness and weakness, and CBC revealed hemoglobin of 7 gram percent and MCV 110. So MCV more than 100 itself definitely will be coming to you thinking of a macrocytic or megaloblastic blood picture. Yes, here the anemia is also low. So we are thinking of a megaloblastic anemia. So megaloblastic anemia, usually the previous year NEET exam also similar kind of questions were asked, and they were asking you to differentiate between this, what is the folic acid deficiency and what is the vitamin B12 deficiency, what are all the features. So the same kind of questions was asked just 1 or 2 years in the NEET before the NEET exam, and a similar question was asked now in the INICET. So let's see, like from our class discussion also we have insisted this point. So they have given you very important clue, that is normal methylmalonyl-CoA. That is, methylmalonyl-CoA is normal, whereas homocysteine is increased. Homocysteine is increased. So you can see from our notes, like actually this methylmalonyl-CoA will be converted into succinyl-CoA with the help of B12. So B12 is essential for the conversion of methylmalonyl-CoA to succinyl-CoA. So if B12 is not there, your methylmalonyl-CoA is going to be increased. But here they have said that it is a normal methylmalonyl-CoA. That straight away tells you that it is not a case of B12 deficiency. Another further clue, see, increased homocysteine. So where is homocysteine coming here? So homocysteine is converted into methionine via this methionine synthase, and both your cobalamin, that is vitamin B12, and your folic acid is or both are essential for this reaction. So if both either vitamin B12 or either folic acid, if they are not there, then your homocysteine will not be converted into methionine and homocysteine levels will be elevated. So increased homocysteine levels with normal methylmalonyl-CoA, we are ruling out vitamin B12 deficiency and we are making a diagnosis of your folic acid deficiency. Folic acid deficiency. So the diagnosis, that is the answer here, is the folic acid deficiency. This is going to be even a repeat topic. So please remember, for this is actually in your NEET exam also similar questions can be asked. And this is actually again a question of like an expected question, that is the maximum amplitude in a thromboelastogram is because of. So this MA, that is the maximum amplitude in the graph, you can see the thromboelastography, the MA, that is the maximum amplitude, it is mainly because of the platelets. It is mainly because of the platelets. Though fibrin also contributes to 20%, so but 80% of this maximum amplitude is because of this platelets. So the correct answer here will be the platelets. Okay. So this thromboelastography, guys, please remember, actually nowadays, actually they have started asking in this more questions on this. Even you can see, you can recollect the last time they have given you the images of the thromboelastogram and they have asked you what is the investigation which is shown in the image. So this time they are asking you what are the components of that investigation, what is the property of this graph, like that they have started asking. So thromboelastogram, it is the maximum amplitude here is because of the platelets. So the next question, if you can see, a 5-year-old child presented with multiple osteolytic lesions in the skull. So child presenting with a multiple osteolytic lesions in the skull, and they've given you the biopsy of the lesions as shown in the image. And the very important thing, they have given you a similar image like this. And what are the things actually you can better appreciate in this kind of image which they have given is, it is the tumor cells which are showing a nuclear groove. Can you see this? So this is the nuclear groove. Yes, this is the nuclear groove. So this is the nuclear groove. The tumor cells will be having the nuclear groove, and we have discussed this nuclear groove as a coffee bean appearance. Yes, coffee bean appearance. And also you can see lot of eosinophils. And another important clue they have given you is that yes, these cells are positive for S100 and CD1A. S100 and CD1A. So this is a very important clue. And with this child with the osteolytic lesions in the skull, and also this tumor cells positive for S100 and CD1A, the diagnosis is Langerhans cell histiocytosis. Yes, guys, you will remember what we have discussed. And please remember, these tumor cells on electron microscopy will be actually showing this Bilbek granules, that is the electron microscopy, actually this tennis racket appearance. Another marker which I insisted during our class is the Langerhans. Okay, Langerhans. Apart from CD1A and CDS100, these cells are also positive for the Langerhans. And just recollect what are the three types, that is the eosinophilic granuloma, lateral CV disease, and Hand-Schüller-Christian disease. You will be remembering that calvarial defect, that is the skull defects, will be more in this eosinophilic granuloma, and the Hand-Schüller-Christian disease, the triad of multiple bone lesion, exophthalmos, and diabetes insipidus. Okay, so moving on to the next question. And this is the classical image they have given you in your exams. That is a child presenting with an umbilicated lesion in the face. Child presenting with an umbilicated lesion in the face, that is actually very typical. With the history itself you can make, that is a case of a one of the important differential is that molluscum contagiosum. And also they have given you this kind of image. Okay, you can see here this a crater shaped appearance, that is a cup shaped appearance. And you can see this image actually we have discussed during our workbook. And these are all the eosinophilic cytoplasmic inclusion, which are called as the molluscum contagiosum bodies. Yes, they are seen in molluscum contagiosum. So these bodies are called as molluscum contagiosum bodies. And these are all the things very brightly eosinophilic. And what is the, guys, what is the other name for this molluscum contagiosum bodies? It is the HP bodies, that is the Henderson-Patterson bodies. Henderson-Patterson bodies. So they have given you the image, and this image is a very classical one. And this is a case of molluscum contagiosum. Molluscum contagiosum. The next question is, a 55-year-old chronic smoker presented with the dyspnea and hemoptysis. I told you, like from the lung cancer itself, they have given you the IHC marker and they are asking you the diagnosis. Yes. So here they have given you the history of chronic smokers. So which is just cancer which is strongly, highly associated with the smoking. Just have it in your mind. And what are all the important clue? Another clue they are giving here, that is the tumor cells are positive for chromogranin and synaptophysin. Yes, as I already said you during the thing, these markers actually chromogranin, synaptophysin, CD57, bombesin, all are positive in your small cell carcinoma. Small cell carcinoma. Yes, I hope you will recollect what are the things actually we discussed. That is the strongest relationship to smoking and a tumor with a lot of paraneoplastic syndrome. You will think of small cell carcinoma, and it is the actually BCL2 positive, very, very important. And lung cancer with worst prognosis is your small cell carcinoma. So please remember the markers: chromogranin, synaptophysin, CD57, and bombesin. Yes, and the diagnosis here is the small cell carcinoma. The small cell carcinoma. The next question, which of the following is responsible for the oncogenesis of the virus, human papilloma virus? That is, which are all the proto-oncogenes, which is responsible for causing the cancer in case of human papilloma virus. So with the human papilloma viruses, two questions were asked, one in the morning and one in the afternoon. Actually, in the morning, they were asking about this proto-oncogenes. Proto-oncogenes are the oncogenesis in HPV, that is mainly by the E6 and E7. So E6 and E7 are mainly in the proto-oncogenes. And in the afternoon session, actually, they were asking you about this vaccination. So vaccinations are mainly targeted at the L1 and L2 of the proteins of the human papilloma virus. So guys, please remember L1, L2 vaccination targeting the proteins, and proto-oncogenes of human papilloma virus is your E6 and E7. And guys, we have discussed, I hope you will remember what are all the properties of this E6 and E7, which we discussed during our session. Yes, E6 increases the telomerase expression, and E6 also inhibits the P53. Yes, and E7 inhibits the P21. That is what will happen because if P21 is inhibited. So there will be increased cyclin D. So increased cyclin D and the tumor suppressor gene, that is the retinoblastoma, will be inhibited. So if what will happen if tumor suppressor gene is inhibited, so that cells will be keep on proliferating. So remember this point also. All of the following are true about sirtuins except. Is this point actually I repeatedly stressed during our sessions. I hope you will remember that. So sirtuins. So let us see what we have discussed about the sirtuins. Actually, we have discussed that this is a NAD dependent protein deacetylases, and it inhibits the metabolic activity. Okay, and sirtuins actually reduces the apoptosis, and it increases the longevity. So if you see this option, that is a type of histone deacetylase. Yes, this is a type of histone deacetylase. This is true. And there are 7 types of sirtuins actually, which are denoted as SIRT1, SIRT2, SIRT3, like that. Up to 7 types of sirtuins are there. Yes, this is also a right option. As I said, the sirtuins or the genes, actually the compounds which increases the longevity. So coming to this option, so here, please remember, clearly see here, they are mentioned as increases insulin resistance and glucose, decreases the glucose metabolism. But sirtuins are the compounds which increases the insulin sensitivity. They makes the cell sensitive to insulin. So insulin is an anabolic hormone. So when insulin is more, that is, it increases the insulin sensitivity and thereby increasing the glucose metabolism. So there only actually it acts to increases the longevity. And also here, please remember, calorie restriction is also an important point for this prevent the aging. So the option here, that is the increased insulin resistance and decreased glucose metabolism, is the wrong option which we have to choose. Which of the following combination is true? This, they have given you the list of these proto-oncogenes and the cancers which are actually seen in this proto-oncogenes. So you can see here, like I have given you the table in the workbook, and almost all the 4 options are came from this workbook only, from this combination only. So this is really very high yield topic, and every exam they are asking at least 1 or 2 questions. Definitely you can solve if you see and go this table column. Yes. So let's see here. C-KIT, it is for GIST, that is a gastrointestinal stromal tumor. KRAS mutation, that is seen in a lung cancer. ERBB2, breast cancer. And PDG for B, that is the astrocytoma. So all the 4 options are right here. Yes, C-KIT, GIST, KRAS lung, ERB2, breast cancer, PDGF for B, astrocytoma. So this is a very, actually like a very high yield tabular column. Every exam they are asking a question from this tabular column. Yes. So all of the following are poor prognostic factors in ALL, except this is also a very repeat topic which I stressed you, and this is also a similar kind of a tabular column which we discussed, like the favorable and unfavorable prognostic factors in the ALL. So all of you guys will be remembering that if the cell count is less than 10,000, it is favorable, and it is more than 2 lakh, it is unfavorable. So this ALL actually common in children. So in 2 to 10 years, it carries a favorable prognosis. Whether less than 1 year or above 10 years, it carries a poor prognosis. And node involvement, liver involvement, spleen involvement, testicular, CNS involvement, all carries a poor prognostic factors. And you will remember this translocation 922 and the translocation 411, that is unfavorable prognosis. Yes, all of the things were asked in the options, were given in the questions. You see here, age less than 1 year, yes, it is a poor prognostic factor. 922 again a poor prognostic factor. Translocation 411 again it is a poor prognostic factor. Whereas hyperdiploidy, as you can see from this tabular column, which I have told you, that hyperdiploidy is a favorable prognostic factor. Favorable prognostic factor. Now moving on to the next question. A 8-year-old boy presented with a repetitive knee swelling and bleeding into the joints was observed. So the child was having a repetitive knee swelling and they have given you clearly that it is a joint bleeding, joint bleeding. So what is it? It is a boy. Okay, it is a guy who is got affected and all of the following are true about this condition. Yes, they will give large joint bleeding, muscle hematoma. So I told you to remember that is a hemophilia case. So hemophilia is linked, inherited as an X-linked recessive disorder. Yes, it is correct. And the bleeding after minor trauma is seen. Definitely, it can be seen. And males are affected and females are carriers. Yes, males are commonly affected. Some are saying that males are commonly affected was in one option. Yes, males are commonly affected. And gum bleeding is common. See this gum bleeding. So if you carefully see what I told you in the classes, this is actually how to differentiate between a platelet and a clotting disorders. So this actually, I told you, insisted you that the bleeding from superficial cuts and scratches, all these things actually will be seen in a platelet disorder. And even this gum bleeding and gingival bleeding are characteristic of the clotting bleeding disorder. That is a platelet. But this big joint involvement, that is a hemarthrosis, deep dissecting hematoma. So all these things, if big things are there, then you think of disorders of clotting. Okay, so gum bleeding is not actually a characteristic of a clotting disorder, and gum bleeding, if it is there, definitely this is the option which was false in this case of hemophilia. So this is the option which we have to choose. Okay. So the next question, which of the following is true about hereditary spherocytosis? The first option was given was increased MCH is pathognomonic of this condition. Guys, please remember it is not MCHC and not MCH. So I hope you remember the point which I stressed, this MCHC. The only condition in which MCHC is elevated is your hereditary spherocytosis. Is that then the spherocytes, the MCHC is elevated. So spherocytes as a cells are more smaller, that is spherical in shape. The hemoglobin getting concentrated in the spherocytes with a less surface area. So increased MCH is a wrong option. It should be increased MCHC. At least 25% of the cases are family history. Yes, definitely there will be many of the cases you can get a family history in case of hereditary spherocytosis. This is a correct option. And splenectomy does not protect against gallstone. This is wrong. So splenectomy, actually there will be splenomegaly and the RBCs are prematurely killed in the spleen only. So usually splenectomy is offered as a treatment in your hereditary spherocytosis. So splenectomy protects against gallstone. So this is a wrong option. Gallstones develop by 4 to 5 years of age. Actually, within this 4 to 5 years of age at all, these gallstones will not develop and it will take little later to develop this gallstone. So this is also a wrong option. So the correct option here is that the stressing is the family history. At least 25% of the cases are family history. Name itself says hereditary spherocytosis. Yes, hereditary. The disease is hereditary. So this is the right option. So as you can see, we have stressed here this triad of hereditary spherocytosis, that is the splenomegaly, jaundice, and the hemolytic anemia. And deficiency of the anchorin causes hereditary spherocytosis, and deficiency of the spectrin causes hereditary elliptocytosis. Yes, and autosomal dominant inheritance and gallstones, you will be remember, and I stressed this, MCHC will be elevated, osmotic fragility will be positive, and EMA, okay, flow EMA will be the diagnostic of choice and standard test. Yes. So coming to the next question, a 45-year-old male presented with megaloblastic anemia. He gives a past history of surgery in the GIT 1 year back. Resection of the which part of the intestine is not responsible for this condition? For answering this question, just turn the pages of your workbook where I have shown you this image. So in this image actually which we have discussed about where and all this vitamin B12 is goes in this intestine, and what happens at each part we have discussed, no. So mainly in the salivary gland actually this haptoporin proteins are produced, and this gastric parietal cells will be producing this pepsin, and here in the gastric acidity will be separating this haptoporin, and means will be separating this binding protein, and the vitamin B12 will be binding with the haptoporin complex. So gastric is stomach is very important because actually parietal cells which produce the intrinsic factor is also there in the stomach. So, and in the what happens in the duodenum, if you can see duodenum with the help of this pancreatic enzymes, there will be splitting of this haptocorin, that is the binding protein which is produced in the salivary gland, no. So that haptocorin and B12 complex will be split. That splitting happens at the duodenum. So the tumor, the vitamin B12 actually just passes through this intestine with this intrinsic factor combination, and this vitamin B12 is absorbed in the ileum, if you can see from this picture. Yes, so what are all the organs involved here? Here the stomach is involved, here the duodenum is involved, and ileum is involved, and the jejunum is not involved here. So stomach, duodenum, and ileum is involved. So the section of jejunum will not be responsible for this condition. Okay, so the answer here is the jejunum. A very applied type of questions, they have this type of match the following. Yes, Merjolin's ulcer. They have asked you the different kind of lesions, and they have asked you what type of pathology or pathological investigations you will do in each kind of this surgical cases. So Merjolin's ulcer. What is the main worry in the Merjolin's ulcer? So Merjolin's ulcer, the main worry, actually the main thing we want to rule out is whether this lesion has developed a squamous cell carcinoma or not. So we want to know whether there is a squamous cell carcinoma developing in the Merjolin's ulcer. So to know that it is a carcinoma, you should prove that there is an invasion of the tumor. So you need a deeper tissue to prove that it is an invasion. To prove that this is tumor is invading into this particular area, you need a deeper lesion. So only wedge biopsy can provide you such deeper lesion to assess the invasion. So Merjolin's ulcer, you will be doing this wedge biopsy. You will be doing a wedge biopsy. Sarcoma. Sarcoma will be a large mass, say for example a retroperitoneal mass. So it will be a retroperitoneal mass, and you cannot excise the entire thing. And you can also take, cannot also, it will be very difficult in location. You cannot also take a wedge biopsy there. So usually what they will be doing in cases of sarcoma, they will be doing a core needle biopsy with a needle. With the help of a core needle, they will be taking a linear course of the tumor tissue. A linear, that is a straight line. A linear core of tumor tissue will be taken in cases of this sarcoma. So core needle biopsy will be done in cases of sarcoma. If it is a single cervical lymph node swelling, say for example, a single cervical lymph node, which is like a medium size. So a single cervical lymph node, and some cases in which FNAC cannot be done in very small lymph node cases. So in those cases, even if it is a single thing, usually if it is a multiple or big, usually they will be doing FNAC, but it is a single cervical lymph node, just excise it and just see it under the microscope. So excision biopsy will be seen, will be the method of choice in a single cervical lymph node swelling. And solitary nodule of thyroid, actually it is a very important and very commonly done test for the solitary nodule of thyroid is you do a FNAC, and it will be better if you do in a ultrasound guided manner. Okay, because you can sometimes you may hit only the cystic lesion. So you want a solid lesion also to be examined. So only a ultrasound only will tell you whether this is a cystic lesion, whether this is a solid lesion. So which area you want to aspirate. So those guidance will be better if you do in an ultrasound mode. So ultrasound guided FNAC will be done in cases of solitary nodule of thyroid. Which of the following special stain is used to stain iron particle? The next question. So this is actually I told hundreds of times, guys, about this stain for iron. And this is Pearl's Prussian blue. Yes, from a thing, you can see that pearls Prussian blue, and also you will be remembering the principle. You can also remember the principle which I insisted, that is ferrocyanide will be converted into ferric ferrocyanide with the help of this pearl stain, and it will be showing this blue color. And guys, you will be remembering where all the places will be doing this pearl stain, and especially the iron deficiency anemia, and to assess the iron overload, and all these cases you will be doing this pearls Prussian blue. And in hematological conditions, I mean in sideroblastic anemia also will be doing this application of the same pearl stain is many places in pathology. So Mason Fontana, what is this? Which stains actually this Mason Fontana? Mason Fontana and Mason Trichrome. Though the name Mason is there, Mason Fontana is for melanin, and Mason Trichrome is for your collagen fibers. Mason Fontana stains the melanin black in color, whereas Mason Trichrome stains the collagen in blue in color. And you will be remembering von Cosa is a special stain for calcium. Special stain for calcium. And as I said already, that actually this exam they have given very much importance to your interleukins and the cytokines. And this is the another example where there is actually a straightforward question. These type of questions, no, actually, if you know the fact, you can answer. Like this type of match is actually somewhat very, actually I say that it is somewhat advantageous, because actually even if you know at least one or two options, definitely you can with the available options, you can pick up at, you can rule out few things, and you can actually shuffle between the two things, actually match the following, like this kind of things actually is actually quite advantageous for the students, so I feel it. So they have asked you about the different types of interleukins and what are all the cells that these interleukins recruit. Yes, this interleukin 17, you can see from this tabular column, which I showed you about these different types of T helper cells, that is the T helper 1, T helper 2, and T helper 17, and what are all the cells, and what are all the functions, or what are all the cytokines which are produced by these cells, and what are all the cells they recruit. So this interleukin 17 actually involved with this neutrophil and interleukin 5 eosinophil. This point actually, interleukin 5 with the eosinophil, I stressed during your type 1 hypersensitivity reaction. Yes, in type 1 hypersensitivity reaction, eosinophils will come in the late phase step. No, at that time, this interleukin 5 plays a major role. Then interleukin 9 actually is involved in for the mast cells, and interleukin 13 is for the dendritic cells, macrophages, that is the dendritic cells and the antigen presenting cells. So this interleukin 13, please remember that. A very repeat question, another repeat question. A 16-year-old girl presented with a short stature, webbing of neck, widely placed nipples, streaked ovaries, and most of the classical features is absence of pubic hairs and amenorrhea. Laboratory findings revealed increased LH and FSH. So what is the most likely diagnosis is, guys, this is a very classical picture of your Turner syndrome. And you can see from our notes, actually, we have discussed about this cystic hygroma also, which is in connection with this Turner syndrome. Okay. And congenital heart disease, the most common, please remember, it is a bicuspid aortic valve. And I hope you remember the phrase which I told you in connection with this Turner syndrome, that is a menopause before menarche. That is the accelerated loss of oocytes will be there, no? So this will be the reason for the streak ovaries seen in case of your Turner syndrome. And please remember another important MCQ with this Turner syndrome, there is increased risk of gonadoblastoma. Gonadoblastoma. Yes, the next question is, a 35-year-old patient presented with the symptoms of passing dark-colored urine. So dark-colored urine, remember this word I told, dark-colored urine, high-colored urine, cola-colored urine, all tells you that there is hematuria. Yes, so here there is a hematuria. It is a known case of G6PD deficiency disorder. Ingestion of which of the following medication would have most likely triggered the hemolytic episodes? So they've given you the list of 4 drugs. And actually what confusion actually came is, actually guys, few guys got confused between this chloroquine and primaquine. Yes, please remember, both chloroquine and primaquine can cause these hemolytic episodes in case of G6PD. But the first important thing, as you can see from our notes, actually here I have mentioned that primaquine is the first drug, because primaquine always, usually it will cause, whereas chloroquine, some people it may cause and some people it may not cause. So some people, chloroquine may cause, some G6PD deficiency patient, chloroquine may cause, and some people it may not cause. So primaquine usually causes. So if you ask me to choose one thing between primaquine and chloroquine, it is the primaquine which will be usually should be picked up. Okay, just remember the other drugs like sulfonamides, nitrofurantoin, dapsone, cotrimetazole, even naphthalene balls also can precipitate hemolysis. Hemolysis, yes. So this the answer here will be the primaquine. Primaquine. I hope you will be remembering your this sulfhydryl groups, that is of precipitating this hemoglobin, and also you'll be remembering the Higgs bodies, blister cells, helmet cells, ghost cells, all the cells are connected with this G6PD deficiency. The next question, and it is a quite a controversial question, but please remember, I'll try to explain these questions in a much elaborated manner. So here the history asked is 40-year-old male presented with a history of fever, weight loss, and hemoptysis. And people were saying that actually there was an option, there was a word like saddle nose deformity. So the patient had a saddle nose deformity with history of fever, weight loss, and hemoptysis, and revealed multiple cavities in the lung. And another important clue actually they have given in the exam, that is in the question, is that this patient has a caseating granulomas with giant cells. Caseating granulomas with giant cells. So please remember, guys, out of the options which got confused between confused in most of you, that is most of you got confused with this tuberculosis and this granulomatosis with the polyangiitis, it is the vaginous. Yes, both tuberculosis and granulomatosis with the polyangiitis can cause multiple cavities in the lung. Okay, and hemoptysis can occur both in TB as well as vaginous. Okay, so saddle nose deformity, if it is there, actually usually it is seen in vaginous granulomatosis. But lupus vulgaris, a case of like a tube TB, can cause bony destruction, that is a nasal bone destruction, lupus vulgaris. But here another thing, fever, weight loss, actually they have pronounced here, and which favors a case of TB. But what is the most important thing which should make you to help you to arrive at a diagnosis is a caseating granulomas with giant cells. Caseating granulomas with giant cells. Usually, tuberculosis only will have caseating granulomas. And in your vaginous, that classically they will be saying in most of the cases, that is in commonly you will be seeing in vaginous non-caseating granuloma. So you must have heard in vaginous non-caseating, caseous necrosis usually will not be seen in case of vaginous. Giant cells can be seen both in vaginous as well as in tuberculosis. So with the only the word caseation and also with the symptoms of fever and weight loss, actually more in favor of a tuberculosis rather than a vaginous here. Saddle nose, that is the involvement of the upper respiratory tract, both upper respiratory tract and your lower respiratory tract, if it is involved, definitely you will be thinking of a vaginous. But example in vaginous, if you remember the classical triad of vaginous, one is your granulomas, necrotizing granulomas, both in the upper and the lower respiratory tract, necrotizing vasculitis, and also your crescentic glomerulonephritis, that is the RPGN will be there, which can cause hematuria. But here hematuria symptoms they are not given, and any vasculitis related symptoms they are not given. If the examiner also wants to make a diagnosis of your vaginous, definitely he would have given this something like a C ANCA positivity. That C ANCA positivity is also not given. Those saddle nose favors a case of a diagnosis of your vaginous with this fever, weight loss, and also caseating granulomas. We will favor a diagnosis of a tuberculosis because vaginous usually will cause a non-caseating granuloma. So we'll make a diagnosis of tuberculosis. Here the correct option will be a tuberculosis because of the caseating granuloma. And I hope you will remember this type of the giant cells. That is the Langhans type of giant cells which we discussed in tuberculosis. All of the following are true about a gastric cancer except. Again, a straightforward question from our notes, which is if you turn our notes page, workbook page, you can see that in their box, actually, we have discussed about this types of the sporadic gastric cancer, what are all the mutations which are seen in different types of gastric cancer. Exactly the three options were asked in the question. You can see here, P53 mutation can seen in diffuse and intestinal type, and in a sporadic diffuse type, there will be CDH1 mutation. CDH1 is nothing but E-cadherin. Yes, CDH1 is E-cadherin. So E-cadherin mutation is actually seen in case of diffuse type of gastric cancer. This is true. This is very much true. And again, depth of in coming to the next option, depth of invasion is not a prognostic factor. Actually, this is a very wrong option because depth of invasion, based upon the depth of invasion only, you are categorizing them as a superficial gastric cancer or advanced gastric cancer. So depth of invasion is an important prognostic factor. So this is a wrong option. Most gastric cancer are hereditary. Yes, most cancers are hereditary. And another option is loss of function mutation of WNT pathway is seen in the intestinal type of gastric cancer. So actually, if you can see here, in the intestinal type of gastric cancer, there is gain of function of mutation of the beta-catenin. That is the beta-catenin, that is the WNT pathway. So the loss of function they have given, so it is not loss of function, it is actually a gain of function. So guys, please remember the things which we have discussed. That is the two types of gastric cancer. That is the intestinal type, when you can see lot of intestinal glands, that round glandular structures. And diffuse type, remember what are the things I told you to remember in the diffuse type? This kind of cells. What are these kind of cells? With a peripherally eccentrically placed nucleus? Yes. These are all the signet ring cells. These are all the signet ring cells. And what is the classical gross appearance of this type of tumors? Yes, it is linitis plastica or the leather bottle appearance. Linitis plastica. Yes, in diffuse type, there is a diffuse involvement of the gastric wall, whereas in the intestinal type, actually it is a focally and ulcerative or a proliferative tumor. Moving on to the next question. Hereditary angioneuroedema occurs due to the deficiency of. Yes, this is a straightforward things actually, questions actually, which we have discussed about the different types of deficiency of the complement proteins and their disorders. If you remember the point which we highlighted, that is hereditary angioneurotic edema occurs because of the deficiency of C1 esterase inhibitor. C1 esterase inhibitor. Yes, I told you to remember the other table, other points, other deficiency of the other complement proteins also. Just remember, this can be asked in the subsequent exams. Okay, so the answer here, hereditary angioneurotic neuroedema, is due to the deficiency of C1 esterase inhibitor. C1 esterase inhibitor. A patient presented with a hemoglobin of 5 gram. His reticulocyte count is 9%. What is the corrected reticulocyte count in this patient? So corrected reticulocyte count in the patient is nothing but the formula is, as I told in your class notes, that is the reticulocyte count into patient hematocrit into divided by normal hematocrit. So what is the reticulocyte count here they have given? Reticulocyte count they have given is 9. So into patient hematocrit by normal hematocrit. Patient hematocrit divided by normal hematocrit. So here they have given you the hemoglobin value, and approximate actually you can get this hematocrit is nothing but hemoglobin into 3. Hemoglobin into 3. This is actually a rough formula. So hemoglobin here it is 5 gram percentage. So the patient hematocrit we can take it as a roughly as a 15. And a normal hematocrit, all of us will be knowing this, it is around 45. Around 45. So you can see here 3 and 3. So the corrected reticulocyte count is 3. Okay. So 15, 45, 3 and 3, 9, 3. Okay. So this formula actually just a rough formula only. It is not an exact formula, but roughly formula. Hemoglobin, HB, hemoglobin into 3 usually will be giving you this approximately the hematocrit. Yes. If you take normal hemoglobin as 15, And 15 into 3, that is 45, is the hematocrit in this patient. So similarly, we can calculate with the hemoglobin value, the hematocrit also. Yes, this formula also we have discussed. Yes, the class switching occurring in IgM and IgD antibodies is due to, yes, if you can see our class notes, actually we have discussed like what are all the T cell dependent mechanism of T cell dependent activation. And yeah, here we have discussed about the isotype switching as well as this affinity maturation. So isotype switching is nothing but actually when the antibodies are shifting, there will be production of different classes of antibodies, that is the IgG, IgA, and IgE from the IgM and IgD. That is the class switching. It is mainly due to the somatic hypermutation. So somatic hypermutation helps that to produce the body to produce antibodies of different affinity. Okay, different thing. So this is the mainly because of the somatic hypermutation. A 5-year-old boy presented with a hemolytic facies and a history of repeated blood transfusions. On examination, he had a splenomegaly. What are all the appropriate investigations needed in this patient? Yes, with the diagnosis of hemolytic facies, that is the thalassemic facies or mongoloid facies, and history of repeated blood transfusion, that is the thalassemia major. Yes, thalassemia major. So we are making a diagnosis of thalassemia major. So repeated blood transfusion, splenomegaly. So in cases of thalassemia major, mainly you can see the peripheral smear examination to make a diagnosis of microcytic hypochromic anemia and also this high performance liquid chromatography. Yes, as you can see from here, I told this HPLC is mainly needed for this quantification of the HB in percentage. And I hope you will be remembering that what are the things actually we have discussed, that is in the chipmunk facies or the mongoloid facies. And I hope you will remember the target cells and the microcytic hypochromic picture and the marked anisopoikilocytosis with this, in this case of thalassemia. So here the investigations which we have to do is the peripheral smear examination as well as this HPLC, that is high performance liquid chromatography. Next question, a 40-year-old female who presented with a thyroid swelling was diagnosed as papillary thyroid carcinoma. All of the following can be seen in the histopathology except, yes, this is papillary carcinoma also, twice it was asked. So papillary carcinoma, definitely you will be remembering the things which we have discussed, that is the nuclear clearing will be there. Yes, see this, nuclear clearing will be there. And here also you will be seeing the nuclear grooving and the dystrophic calcification which can occur in papillary carcinoma, that is the thyroid, that is the stroma bodies will also be seen here. Whereas the follicular pattern of papillary carcinoma is also one variant is there, but it is not like an increase in follicles. In papillary carcinoma, the predominant pattern is papillary. But here the option given is increase in follicles. Okay, so papillary carcinoma, the predominant pattern is papillary. So this will be the wrong option and which we have to choose in this case. Which of the following are components of MEN2A syndrome? Guys, please remember the tabular column which we discussed where about the components of this MEN syndrome. MEN1, that is a Vermeer we have discussed, and MEN2A simple, MEN2B, that is a Gorlin syndrome, which I told you in the class. Yes, so you can remember, you can see from this tabular column, your medullary carcinoma will be seen in MEN2A. Parathyroid hyperplasia will be seen, and pheochromocytoma will also be seen in your MEN2A, and it is not optic nerve glioma will not be seen in MEN2A syndrome. So this is actually a very straightforward and also from a very repeat high yield topic. I hope all of you would have done this question rightly. And again, see this, how many thyroid cancers? A question from how many, two from the papillary and another from another thyroid cancer. See here. So 48-year-old female presented with a thyroid swelling and surgical removal was done and they have given you the histopathological image. So I hope you will be remembering on seeing the thyroid tumor. But this pinkish material, homogeneous. Homogeneous means uniform, eosinophilic, pinkish material throughout the tumor. What is this? Yes, this is the amyloid. This is the amyloid. So guys, if you see amyloid in a thyroid tumor, I hope all of you will be choosing the option of a medullary carcinoma of the thyroid. Medullary carcinoma of the thyroid. Yes, I hope you will remember the things which I told you, that it is Congo red positive. And what are all the tumor marker? What is the tumor marker for this medullary carcinoma thyroid? It is calcitonin. Calcitonin. Yes, and also remember the sporadic and the familial medullary carcinoma thyroid. Yes. Coming back to the question, a 20-year-old female presented with a pelvic mass. surgical excision of the ovarian mass, and they have given you the image of an ovarian tumor. And guys, it was quite actually, some of you are saying that actually it was a blurred image. And if you can see here, and you can see both the teeth will be there and also the hair follicles. So it is a straightforward a case of a mature cystic teratoma. So it is a cystic tumor. You can see the tumor is appearing very cystic in nature. So mature cystic teratoma. And definitely the other option, immature tumor, teratoma, and mucinous cysternoma, serous cysternoma will not be fitting here. I hope you will be remembering the point. The point which I told you is the Rokitansky protuberance. Yes, remember in a teratoma, you have to look for a point of protuberance. That is, a area will be somewhat protruding. That is a Rokitansky protuberance, where you can get more number of tissues, as well as the immature tissues will be there in case of a Rokitansky protuberance. And just remember, monodermal teratoma, that is a single teratoma, single derm derivative, that is a struma ovary thyroid will be there, and struma carcinoid, only carcinoid tumor will be there. And this is also the case actually which we discussed during our workbook discussion. Which of the following is seen in children of mother exposed to diethyl stilbosteroid? Yes, I hope you will remember from our notes. Vaginal intrauterine exposure of diethyl stilbosteroid. It was clearly said that it predisposes to clear cell adenocarcinoma of the vagina. Yes, mothers who got exposed to this diethyl stilbosteroid, the children will be later developing clear cell adenocarcinoma of the vagina. This is a very important repeat topic. Yes. The next question, very simple question, that is a cyclooxygenase enzyme has a role in which of the following pathway, or which of the following mechanism, which of the following compounds? Yes. If you can see, if you can remember this picture which I showed you in your workbook, that is the two pathways, that is the cyclooxygenase and the lipoxygenase pathway. You can see these prostaglandins are involved in the cyclooxygenase pathway. Okay, so the straightforward answer here is the prostaglandins, whereas leukotrienes are involved in the lipoxygenase pathway. Okay, leukotrienes and lipoxins. And kinin are nothing but actually it is the plasma-derived mediator, plasma-derived chemical mediator. Yes. Moving on to the next question, guys. A 55-year-old smoker presented with hemoptysis, and again you can see it is a lung mass. So it is a lung tumor. So here, see how they are asked about adenocarcinoma, they were asked about the small cell carcinoma, and now they have given you the tumor cells are positive for P40. Yes, P40. If a lung tumor is positive for P40, definitely it is a diagnosis of a squamous cell carcinoma. Squamous cell carcinoma. See, from the thyroid tumor, they were asked some papillary carcinoma twice, and also the medullary carcinoma. The lung cancer, they were asked about the small cell carcinoma, squamous cell carcinoma, and adenocarcinoma, P40. Please remember, I hope you will remember the things which I told you in the class, that is the cytokeratin, they are positive for the cytokeratin, P63 and P40. And please remember, squamous cell carcinoma is associated with hypercalcemia and also cavitation and the Pancoast tumor. Yes, so the answer here will be the squamous cell carcinoma. A 35-year-old HIV patient presented with a history of chronic diarrhea. Examination revealed ooze cyst of 4 to 6 micrometer. Actually, this they have given you, I think, a stool sample of to making a diagnosis, and the ooze cyst is of 4 to 6 micrometer. I hope, though I have not touched the stool sample, but actually, if you remember during our discussion, we have discussed this image, that is the histopathological image of this cryptosporidium, and which we have discussed, that is a commonest cause for diarrhea in an AIDS patient. So here the cyst size is actually, whose cyst size is 4 to 6 micrometer, it is cryptosporidium, and the cyclosporidium size cyst will be little higher than this thing. Okay, so here the answer will be cryptosporidium. Here, the next question, actually, a patient presented with the skin lesions. They have shown you some skin lesions with erythematous lesions and of it pointing towards the SLE, and they were asking you the most specific antibody helpful in the diagnosis. If you remember here, anti-Smith will be the most specific one, and the next specific in SLE is the anti-double stranded DNA, which is specific and also correlates with the disease activity. So out of the antibodies which are given here in the option in the SLE, the anti-double stranded DNA antibodies are the most specific one. And the next thing is the match the following, that is the proteins with this carrier proteins, and the globulin Actually, globulin can carry this thyroid hormone and hemopexin and haptoglobin. Yes, haptoglobin is a carrier protein for free hemoglobin and hemopexin is a carrier protein for free heme. So they have asked this kind of match the following. And again, the same thing actually we discussed during the class. Yes, while discussing about this differences between this extravascular and intravascular hemolysis, I stressed you about this haptoglobin and hemopexin. Yes, hemopexin is a protein which binds free heme and haptoglobin is a protein which binds your free hemoglobin. Yes. A 18-year-old male with the thalassemia major received multiple blood transfusions, which is the next best investigation in this patient to assess the iron overload. So it is a case of thalassemia major. You want to assess the iron overload. So please remember, though you will be reflexly thinking that estimating the iron, liver iron, but actually serum ferritin will be the best option here because the serum ferritin is the immediately available form, that is the storage form. So instead of a biopsy, if you biochemical estimation of a serum ferritin, that is the storage form of the iron, so will tell you lot of clue rather than going in for the estimation of the liver iron. Yes, I agree. Liver iron also can estimate iron overload, and your new investigation, that is the T2 MRI, is also can estimate the iron overload. But actually, the next best investigation. So you don't want to go for an invasive or this thing investigation, although you want to have a reliable investigation. So serum ferritin will be the next best investigation to assess the iron overload in case of a thalassemia major. Which of the following cytokines is elevated in Jarisch-Hertzheimer reaction? And it is actually a fact recall based type of questions. And again, I told you know, like lot of questions came on basis of this cytokines and interleukins. This is another example. So Jarisch-Hertzheimer reactions as a recall based, this interleukin 6 as well as your TNF alpha are elevated. Interleukin 6 and TNF alpha are elevated in Jarisch-Hertzheimer reaction. The next question, that is the surface receptor present on the B cells for this Epstein-Barr virus. Actually, this is also a recall-based type of questions. So this Epstein-Barr virus actually enters the B cells via this CD21. This is a point which was highly stressed during our class, that CD21 is a very important receptor in a B cell. Through this receptor only Epstein-Barr virus enters it. Okay, so please remember that. And name the principle of the test, which is done in the instrument. So they have given you the instrument of Sally's hemoglobinometer, like all of you would have done those things during our physiology days and also in pathology practical halls. Yes, Sally's hemoglobinometer, you will be adding this n by 10 HCl. Yes, n by 10 HCl, where you will be adding some blood compound. Okay, blood 20 microliter. So this thing actually mainly this we and you will be waiting for 10 minutes. Why we will be waiting for 10 minutes? Because the principle is you want the acid hematine formation. You want to study the acid hematine. So the answer for this is Sally's hemoglobinometer. That is a very actually very the first year which we have learned, the thing they have asked during our INICET exams. So it is the acid hematine formation. Yes. And the next question, which we will be discussing is the which of the following is not true about parvovirus infection? Parvovirus is the one thing, guys, actually many times which we actually refreshed and revised during our classes is parvovirus is a very important topic. It causes the skin lesion with the slapped cheek appearance. Yes, that is a correct true option. Slapped cheek appearance and also the erythema infectiosum. Remember, fifth disease, erythema infectiosum. And parvovirus, aplastic crisis, yes, parvovirus causes aplastic crisis, especially in hemolytic anemias and also in your, especially in the sickle cell anemia. Aplastic crisis is caused by this parvovirus infection. And also you will remember this pure red cell aplasia parvovirus can cause. And non-immune hydrops is during this pregnancy, actually this parvovirus infection is there, it can result in non-immune hydrops whereas the other option actually is not fitting into the other things, that is the SLE non-erosive arthritis, which is actually not seen in the case of a parvovirus infection. So this will be the option, correct option in this question. Yes. I hope you will be refreshing the parvovirus infection. That is a fifth disease or erythema infectiosum, and I hope you will remember the dog-ear appearance of the cytoplasm. The cytoplasmic protrusion, that is, it prefers this erythroblast, no pro-erythroblast stage is mainly affected in this parvovirus infection. This a dog-ear appearance of this cytoplasmic protrusions. You will be remembering that. Yes. So, guys, if you see the overall analysis of this paper, actually, as I told, it is a tricky paper. Though you can see like with the examples, classic examples which I showed, most of them the repeat topics and the high yield topics, and actually we are very happy that it is most of the things you can get it seen from our workbook based discussions. Okay, so guys, I hope you have done this thing, and those who have committed some silly mistake or marked it wrong, don't worry, take this as a learning experience, and definitely you will be cracking a nice good rank in your INICET exams, if not definitely in the coming NEET exams. So don't lose hope. Definitely, this will be a practicing exams and many of you a life-changing exam. So thank you all for your patient listening. Thank you all. All the best.